Good afternoon. I'm Dr. Phoebe Thorpe, and welcome to CDC's August 2014 Public Health Grand Round session, Time for Public Health Action on Infertility. In addition to joining us here, Grand Rounds is available on all your favorite social media websites. We also have a featured video segment on YouTube called Beyond the Data, which is posted shortly after the session. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, health educators, and others. As part of the continuing education process, I would like to tell you that we have nothing to disclose. All of this information is available on the Public Health Grand Rounds website. We have partnered with the CDC Public Health Library and Information Center to feature scientific articles relevant to infertility. The full listing is available at cdc.gov/scienceclips. Here is a preview of upcoming Public Health Grand Rounds sessions. Also, as a gentle reminder, please silence cell phones and other electronic devices. In addition to today's outstanding featured speakers, I'd like to take a moment to acknowledge the important contributions of the individuals listed here. And now, it is my pleasure to introduce Admiral Robin Akeda, Deputy Director of the Office for Non-Communicable Diseases, Injury, and Environmental Health at the CDC. Thank you for joining us.
Thank you, and good afternoon to everyone. Infertility is a disease that affects both women and men. Around 6.7 million reproductive aged women in the United States, or 12%, have some difficulty getting pregnant or carrying a pregnancy to live birth. Approximately 9% of men report some type of infertility. The effects of infertility and its treatment can be devastating and include psychological stress, anxiety, and depression. Although infertility is a medical diagnosis, many health insurance plans do not cover the cost of infertility treatments, and as a result, the high out-of-pocket expenses associated with these treatments can lead to disparities in access to treatment, use of less effective and less safe but lower-cost treatment, and a desire for multiple births in order to decrease the possibility of additional procedures. The use of infertility treatments has increased over time. This is an important public health issue because these treatments increase the risk for multiple births, which can in turn lead to adverse maternal and infant outcomes, such as preterm birth. Many of the known causes of infertility, sexually transmitted diseases, environmental exposures, obesity, and smoking, are preventable. Public health interventions, such as the comprehensive screening and treatment for sexually transmitted infections, as well as chronic disease prevention and health promotion programs, are important steps towards the prevention of infertility in men and women. The goal of any infertility treatment is the birth of a healthy singleton infant. Multiple births due to infertility treatment can be reduced through the use of prudent practice patterns. These would be things like limited and careful use of controlled ovarian stimulation and transferring a single embryo during in vitro fertilization. The National Public Health Action Plan for the Detection, Prevention, and Management of Infertility was just published last month, and it identifies 3 key areas for public health agencies and partners to work together to prevent infertility. And these 3 areas are promoting healthy behaviors that help maintain and preserve fertility, emphasizing the prevention, early treatment, and early detection and treatment of medical conditions that threaten fertility, and then reducing exposures to agents, whether it's environmental, occupational, infectious, or iatrogenic, that threaten fertility. We also need to work together to promote healthy pregnancy outcomes associated with treating and managing infertility and improving the safety and efficacy of infertility treatments. Today, during Grand Rounds, you'll hear about the burden of infertility and the devastating impact it can have on women and men. We'll also hear about the barriers to accessing treatment for infertility and how such treatments can increase the risk for adverse health outcomes for women and infants. Altogether, this tells us, as the title of this session suggests, that now is the time for public health action on infertility. Infertility has many causes, some of which are not yet known. Now is also the time to work together to address these gaps in our understanding of the causes of infertility and to increase opportunities for prevention. Thank you.
And now I'd like to introduce our first speaker, Lee Warner.
Good afternoon. Thank you for coming today to this Grand Rounds. Most of us probably have an idea of what the face of infertility looks like, and I want you to think whether this face, for example, includes the young woman who had chlamydia years ago as a teen, the person who experienced genitourinary trauma, the young adults who are being treated for cancer, or the couple who decide to have children later in life, all of whom are at increased risk for infertility. The effects of infertility can be devastating for those affected and include stress, anxiety, and depression, and have important public health implications. Infertility can affect anyone. And although some perceive infertility as a quality of life issue, both the World Health Organization and the American Society for Reproductive Medicine have recently defined infertility as a disease of the reproductive system. The U.S. Supreme Court actually weighed in on the role of reproduction in the 1998 case of Bragdon versus Abbott, where the court ruled that the ability to reproduce qualified as a major life activity under the Americans with Disability Act of 1990, as reproduction was considered central to the life process itself. Infertility has become a public health issue in the U.S. There are large racial and geographic disparities in many risk factors for infertility. And for those individuals seeking assistance in access to diagnostic and treatment services. For example, African American women are more likely to experience tubal infertility, yet less likely to access care and treatment as compared with white women. As use of treatment increases, the safety issues that surround infertility become more pronounced. Some treatments can lead to multiple gestation pregnancies and increase the risk for adverse health outcomes for mother and infant. Although treatments for infertility have evolved over the past few decades, the long-term effects of these technologies are largely unknown in women and children. Infertility has indications for men and women's health beyond the ability to have children. A diagnosis of infertility can serve as a window into overall health and an opportunity to detect unrecognized health conditions. For example, for men, prior infertility has been associated with increased risk of developing testis and prostate cancers and of premature mortality. We really need to better understand the factors that may contribute to infertility for both men and women across the lifespan. We do not know what proportion of infertility burden can be prevented, but it may be substantial if certain exposures were minimized. And public health has a clear role in preventing these exposures. Some examples include sexually transmitted infections, such as chlamydia and gonorrhea, can lead to pelvic inflammatory disease, or PID, and are leading preventable causes of tubal infertility and scarring. Because of this, CDC promotes early detection and treatment for these infections and also issues national recommendations for the screening, treatment, and partner management. Also, early environmental and workplace exposures can permanently change biologic capacity by affecting gynecologic, urologic, or pregnancy health. These exposures have been associated with reduced sperm quality for men and disrupted menstrual cycle and ovulation for women. More research is needed in this area. The use of medications such as chemotherapy can also result in infertility. Fertility preservation methods should be considered before initiating treatment of conditions such as cancer or autoimmune disorders in reproductive aged males and females, including adolescents. Lastly, there's increasing recognition that modifiable lifestyle factors like obesity and smoking, factors that cause chronic disease and disability later in life, can also impair fertility. Many of these exposures are already well-known threats to public health. The field struggles mightily from the lack of a single standardized definition for infertility, and what's considered a success varies depending on the reproductive outcome used. So some studies use pregnancy, others use live births. The length of time without conception, which often range from as low as 1 as many as 5 years, and whether a woman has had a previous pregnancy. The term infertility generally refers to the inability to conceive a clinical pregnancy after 1 year of trying. And this is to be distinguished from the term impaired fecundity, which refers to the difficulty becoming pregnant or carrying a pregnancy to live birth. This varying terminology makes estimating and communicating the burden of infertility difficult. And today our speakers will use the term infertility more broadly unless otherwise noted. Although most attention focuses on infertility in women, it is a couple-based impairment. One study found that over 30% of cases were due to female factor, but 20% were due to male factor and 40% to issues in both partners. Infertility affects a substantial proportion of reproductive aged men and women, but accurately assessing the prevalence has been challenging, in part because both partners play a role. The best estimates we have for the U.S. come from CDC's National Survey of Family Growth, better known as the NSFG, which has provided nationally representative data on infertility since the early 1980s. Using the most recent NSFG data, for women who were married, 6% were infertile, that is, they did not get pregnant in the last 12 months, while 12% had impaired fecundity, which, remember, means they had difficulty either getting pregnant or sustaining a pregnancy. For men, 9% reported some form of infertility. More women are having their first child later in life, and this is an important contributor to impaired fecundity. So now we're going to take a look at some of this NSFG data again among nulliparous women, that is, those who have never given birth. And these data underscore the importance of advanced age, where over 40% of those 35 years and older report difficulties either getting pregnant or sustaining the pregnancy. The issue of why infertility should warrant attention from public health was first described in a white paper published by CDC in 2010. This represented the first major effort by the agency to consider the broader implications of infertility from a public health perspective and called for the development of a national action plan dedicated to infertility. And I'll talk more about the development of and contents of this historic action plan at the end of today's presentation. And I would now like to introduce our next speaker, Dr. Adashi.
Thank you, Dr. Warner. In this segment, a clinical perspective, I define the objective of infertility therapy, review current treatment options, highlight unintended consequences, and describe efforts to optimize perinatal outcomes. The goal of infertility therapy is to promote the conception and birth of a singleton infant at term, as captured in the acronym BEST, namely birth emphasizing a successful singleton at term. The birth of a single baby at 37 weeks of gestation or beyond at a weight of 2,500 grams or greater is associated with reduced risk to both mother and infant. Data from the latest National Survey of Family Growth suggest that over a quarter of infertile U.S. women sought advice and infertility testing. Amongst those who proceeded to seek treatment, about a quarter required ovulation-inducing drugs and/or artificial insemination. Rarely has surgery been required. Collectively, these latter three treatments fall under the non-assisted reproductive technology category, or non-ART for short. Only 3.1% of respondents made use of IVF, a treatment modality frequently referred to as ART, wherein both eggs and sperm are handled in the laboratory. An example of a non-ART infertility treatment is controlled ovarian stimulation with intrauterine insemination, or IUI for short, which has been available in the United States since 1987. The leading indication for this treatment modality is unexplained ovulatory subfertility. The process involves the use of one of several drugs, such as gonadotropins, which stimulate the development of multiple eggs in the ovary, which at an appropriate time are induced to ovulate with HCG. Timed intrauterine insemination follows suit 48 hours later. Importantly, this technology has been shown to give rise to multiple birth by virtue of its very capacity to trigger the ovulation of multiple eggs. IVF, the most advanced form of infertility therapy, is now being offered nationwide by close to 500 clinics. The leading indications for such treatment are anatomic pathology, male factor, age-related, and unexplained ovulatory subfertility. The process begins with the use of drugs such as gonadotropins, which stimulate the development of multiple eggs in the ovary. Later, following the administration of an ovulatory drug known as HCG, the eggs are surgically retrieved and fertilized in vitro. The resultant embryos, in turn, are then transferred into the patient's uterine cavity or else frozen for future use. The greater number of embryos transferred, the greater the likelihood of multiple birth. IVF was first actualized in the United Kingdom in 1978 with the birth of Louise Joy Brown, the world's first IVF baby. 3 years later, in 1981, IVF was introduced into the United States. Since its inception, IVF gave rise to over 5 million babies worldwide. In recognition of this notable accomplishment, IVF pioneer Robert G. Edwards, PhD, was awarded the 2010 Nobel Prize in Physiology or Medicine. The success of ART and non-ART technologies notwithstanding, both treatment categories have been found to increase the incidence of multiple birth, and in so doing, maternal, fetal, and newborn morbidity and mortality. Although most twin births result from natural conception, 77% of triplet and higher order birth result from either ART or non-ART fertility treatments. As shown here, the leading maternal consequences of birth plurality are gestational hypertension, also known as preeclampsia, gestational diabetes, and preterm birth. Typically, the higher the birth order, the greater the maternal burden. Even with a twin gestation, the risks of every major maternal complication almost doubles. Birth plurality also increases the incidence of fetal and neonatal morbidity and mortality. As shown here, the leading fetal and neonatal burdens of birth plurality are preterm birth, low birth weight, and death. Yet again, the higher the birth order, the greater the fetal and neonatal burden. With an eye towards decreasing the incidence of multiple birth brought about by controlled ovarian stimulation, the American Society for Reproductive Medicine, or ASRM for short, identified and recommended several mitigating measures. These measures include the use of low doses of gonadotropins or their substitution with lower potency drugs such as clomiphene or off-label letrozole. The latter in particular has been reported to affect gonadotropin-comparable per-cycle pregnancy rates in the face of low birth plurality rates. With an eye towards decreasing the incidence of multiple birth brought about by IVF, every effort is being made to expand the use of single embryo transfers. In support of this objective, a broad search is on for embryonic attributes predictive of successful implantation and gestation. One such attribute, a normal chromosomal makeup, also referred to as euploidy, is presently being evaluated in embryonic biopsy material by a sequencing paradigm known as pre-implantation genetic screening, or PGS for short. Embryonic division analysis, also known as morphokinetics, aims for the same endpoint, but in this case by assessing in a non-invasive fashion the pattern of embryonic cellular fission. As the drive towards reducing the incidence of multiple birth continues into the future, the notion of an IVF-dominant future appears to be emerging. Reference is made to a future characterized by a more direct path to IVF with single embryo transfers in mind, a future wherein the use of controlled ovarian stimulation is limited and indeed reserved for those who cannot afford the costs associated with IVF. A future wherein ovulation induction is offered to women in need of assistance with ovulation, and a future wherein the consistent application of these and other measures will in time reduce birth plurality and the attendant risks thereof. It is now my pleasure to introduce Barbara Kolura, President and CEO of Resolve, the National Infertility Association. Barbara.
Thank you. Hello, my name is Barbara Kolura. Many people describe their infertility diagnosis as a profound life crisis. It was unexpected, and people feel ashamed and lost. Listen to how patients describe their infertility journey in their own words. For years, I struggled with infertility, the physical and emotional toll of infertility, the monthly hope, then heartbreak, the appointments with doctors and specialists, the shame and sadness impacted our lives in ways big and small. I lost count of how many times I cried and prayed, beseeching God to fix me so that Nate and I could be parents. For months, I felt broken and alone. From another patient, I was feeling sad and hopeless, and the 3.5 years of trying, miscarriages, and IVF had really taken its toll. I had even told my husband that I was ready to stop trying altogether. Infertility is so lonely and isolating. Resolve, the National Infertility Association, is a patient advocacy organization for women and men who are living with infertility. Our organization provides support, information, awareness, and advocacy on the disease of infertility. We offer 194 peer-led support groups each month currently. Many who suffer from infertility feel isolated and alone. Connecting with others who really get them and know what they're going through can help to normalize the situation and help people navigate their infertility journey. Blogs and social media have served as really a wonderful venue for support and connection. People want to use social media to connect and to get support. Resolve has had to adjust to these changing demographics of the infertility community. For example, we have Walks of Hope, which have grown to really be huge events with hundreds of attendees. People who are proudly walking in a public space touting their infertility. People want to have a cause, and they want to feel as if they are doing something for the community. Resolve founded National Infertility Awareness Week 25 years ago. Today, it is the only federally recognized health observance for people with infertility. Hundreds of events happen that week, and many are hosted by patients. Infertility is a disease. People learn they are infertile from a physician. When presented with a plan for treatment from their physician, patients then often learn that their insurance coverage does not cover the diagnosis or treatment of infertility, and most especially IVF. Employers have to proactively add this type of coverage. Medicare and Medicaid do not cover infertility. Plans can also have unusual requirements. For example, it might require a certain number of IUIs before moving to IVF, regardless of the diagnosis, a certain number of miscarriages before a referral to a specialist, and lifetime max on IVFs, even if the procedures were self-pay and when the employee was at a different job. It's akin to saying to a covered person, we have a lifetime max on 2 pregnancies, and if you had those 2 pregnancies before you came to work here, we won't cover you anymore. Some states have mandated insurance coverage. The Affordable Care Act may not expand coverage for infertility care. We are closely monitoring the implementation, as there is legitimate concern that the ACA may in fact harm the current state mandates. Insurance mandates to cover IVF or to offer coverage were passed in 15 state legislatures. They are not all the same, however, and they all exclude self-insured plans, and many are drafted in such a way that access is actually really tough to get. For example, in Hawaii, you have to wait 5 years, you have to be married, and then you have to use your husband's sperm. There are 8 states with a mandate that actually includes coverage for IVF, and they're more comprehensive in terms of coverage, while 7 states have a mandate to offer, which is more limited and does not include IVF coverage. And then the remaining 35 states have no mandate. Due to lack of insurance, patients are forced to determine if treatment is possible given the out-of-pocket costs, which can be as high as $15,000 for one IVF treatment. Patient resources may only cover 1 or 2 IVF cycles or perhaps no cycles. This forces patients to possibly decide to pursue less costly but also less effective treatments. One couple we know spent 6 years doing IUIs due to the lower cost, and none of the IUIs worked. They finally did 1 IVF cycle and had success the first time. The amount spent on the IUIs was actually equal to the 1 IVF. Precious time, a commodity that is so critical in reproductive health, is lost. Money is spent and potentially wasted. Psychologically, patients can feel anxious and depressed. Finance has become the major driving force in their infertility journey. Moving to IVF with its higher out-of-pocket costs than IUI is a really big step for most patients. Wanting to maximize their investment, patients actually request and desire a multiple birth. It's this 2-for-1 mentality that's in force. Plus, patients don't want to go through the procedure again due to the emotional drain. Why not pay once and get more for your money? This is exactly when risks are ignored and finances and other factors come into play that really have no bearing on the standard of care for a medical procedure. We know at Resolve that when infertility patients get the information and emotional support they need, they reach their resolution quicker, spend less money, and are in a better place emotionally. The financial obstacles are huge to prevent many from getting the care they need. With little or no insurance coverage, those who can afford IVF get it, and those who can't don't. Lack of insurance can lead to poor decision-making and adverse health outcomes due to multiple births. We need to think about the public health implications of lack of insurance coverage for infertility in general. The current system leads to poor outcomes for mothers, fathers, their children, and all of us who care about public health. You will hear more about this from our next speaker, Dr. Dimitri Kissin.
Good afternoon, and thank you, Barbara. One of the main public health concerns of infertility treatments is their association with multiple births. The risk of multiple births in the United States prior to the introduction of infertility treatments was very stable at about 2%. Soon after the introduction of clomiphene, gonadotropins, and ART in 1981, births of twins, triplets, and high order multiples started rising. And currently, 3.4% of all infants born in the United States are multiples. In 1992, the US Congress passed the Fertility Clinic Success Rate and Certification Act. Following passage of the law, CDC initiated national ART surveillance in 1995. Non-ART fertility treatments are not reportable and thus not included in the current surveillance. Since there is no national monitoring of non-ART fertility treatments, I'll be focusing my talk on ART. Starting from the first year CDC collected surveillance data on ART, the number of infants conceived with the help of ART has grown. Over 65,000 infants resulted from procedures performed in 2012. These infants now represent 1.5% of all infants born in the United States and up to 4.5% in states with mandated insurance coverage of ART, such as in Massachusetts. Due to the frequent transfer of more than one embryo during ART treatments, almost half of ART-conceived infants are born as multiples, twins, triplets, and high-order multiples. This compares to 3.4% of multiple birth infants in the general population. Multiple births, as noted by Dr. Adashi, are associated with a myriad of short and long-term poor outcomes, mostly due to prematurity and low birth weight. It was estimated that the societal economic burden of ART-conceived infants born preterm amounts to over $1.3 billion annually. The good news is that many of the adverse outcomes of ART are preventable if only one embryo is transferred at a time. Among live births that resulted from ART, better outcomes are associated with single embryo transfer than with double embryo transfer. Good perinatal outcome, defined as the birth of a singleton infant of normal birth at term, is the ultimate goal of any type of fertility treatment. Now let's talk about effective strategies to improve ART outcomes. Because one of the main reasons for transferring more than one embryo during ART is financial, we looked at the effect of insurance mandates to cover ART. States with a mandate had higher ART utilization than states with no mandate to cover ART, as you can see on the left. This resulted in more than doubling from 1.3 to 2.9% of the infants born from ART. So more couples can get access to otherwise very expensive infertility treatment if insurance covers ART. We also found that ART coverage was associated with more frequent use of single embryo transfer, which of course leads to fewer multiple births. However, only 20% or 1 out of 5 chose to transfer single embryo. So insurance coverage alone is unlikely to solve the problem of multiple births. In the United States, ART practice guidelines are issued by the American Society for Reproductive Medicine and the Society for Assisted Reproductive Technology, and recommend the maximum number of embryos to transfer depending on patient and treatment factors. These guidelines were first published in 1998 and have repeatedly recommended that a lower number of embryos are transferred with ART. Over the years, these treatment guidelines have been effective in decreasing the number of high-order multiple births, triplets and higher, but they have not been successful in reducing twin births. While the percentage of ART procedures with 3 or more embryos increased, procedures with 2 embryos transferred are still going up. And one of the main reasons for slow implementation of single embryo transfer is the financial pressure on patients that result in the desire to maximize the chance of pregnancy and live birth with transferring more embryos than recommended by practice guidelines. Therefore, without addressing the high out-of-pocket costs of ART, guidelines alone are also unlikely to reduce ART-related multiple births. So our data indicate that by themselves, neither insurance coverage of ART nor practice standards is sufficient to reduce multiple births and associated maternal and infant complications. Experience from other countries shows that restrictions on the number of embryos to transfer can be successfully implemented by offering insurance coverage of ART. For example, such strategies have been put in place in Sweden, Belgium, Australia, and New Zealand, where single embryo transfer rapidly increased in the early 2000s, either through legislation or consensus among providers. As you can see on this slide, this has not happened in the US, where single embryo transfer is increasing at a very slow rate. As a result, the risk of multiple births in the United States, while slowly decreasing, remains at around 30%, while other countries rapidly decrease the risk of multiple births. A healthy singleton infant is an optimal outcome of both ART and non-ART fertility treatments. It is important to note that when we are talking about improving the outcomes of fertility treatments, we're actually talking about secondary prevention. We must also pay attention to the primary prevention of the myriad of factors contributing to infertility. And this is why CDC developed the National Action Plan for the Detection, Prevention, and Management of Infertility. And I will now invite Dr. Lee Warner to present highlights from the plan.
Thanks, Dimitri. And so I'll be wrapping the session up by talking a little bit about the plan. CDC is committed to increasing awareness of infertility as a public health issue, and last month we released the National Public Health Action Plan. This plan represents a joint multi-year effort between CDC and many stakeholders, governmental and non-governmental, professional societies, healthcare professionals, and organizations representing people who are coping with infertility, many of whom are in attendance today, either in person in the room or via the web. This plan provides a framework for discussion and collaboration to better understand the public health aspects that surround infertility. We sincerely thank our collaborators, especially for their important insights and perspectives and for their dedication to this effort. So let me talk now briefly about the plan, which can be viewed at the link listed on the bottom of the slide. We also have hard copies in the back of the room, and if you'll send us an email to the address at the end of the presentation, we can mail you one. The plan focuses on the three main areas regarding infertility where public health can play a role, and Dr. Ikeda went over these, so I will briefly mention them. First, to promote healthy behaviors to help men and women maintain and preserve their fertility. Second, to emphasize the importance of prevention, early detection and treatment of medical conditions that lead to infertility. And third, to limit exposure of individuals to hazardous agents that could affect infertility. There are several opportunities for public health to improve the detection of infertility. These include developing standardized case definitions for public health surveillance. The lack of a consistent definition means we often cannot measure and compare infertility across populations in a meaningful way. This undermines public health efforts to address infertility. We also need to improve surveillance efforts. For example, how can we increase the type and amount of information collected on infertility within the existing surveys and surveillance systems, both those that are conducted within CDC, such as the NSFG and National ART Surveillance System, and also those operated outside of CDC. We also need to expand our surveillance efforts, particularly for infertility treatments other than ART. In the area of prevention, we need to better understand the causes of infertility and the extent to which these causes may be preventable. This information would help target infertility prevention efforts. For example, the plan calls for laboratory-based research looking at biomarkers for screening and detection that ultimately would aid in prevention. Support for public education campaigns to promote awareness of known causes of infertility, especially those that are preventable, is urgently needed. Regarding management of infertility, we need to continue monitoring the safety and effectiveness of infertility treatments. Because ART cycles are reportable, we have the ability to monitor use and selected short-term outcomes of ART with CDC's National ART Surveillance System. However, information is lacking on the long-term health outcomes and safety of ART. For non-ART treatments, as Dr. Kissen noted, we know little about their safety or effectiveness despite the frequency of their use. No comparable public health surveillance systems exist, and surveillance is clearly needed in this area. We also need to further promote public health awareness of evidence-based clinical guidelines issued by professional societies, such as the American Society for Reproductive Medicine, the Society for Assisted Reproductive Technology, and the American Urologic Association. We know that healthcare providers may have many questions about this section of Grand Rounds and about the National Public Health Action Plan regarding infertility. Our CDC experts are standing by for a brief period this afternoon to respond to your questions directly and in real time. If you could please email your questions to drhinfo@cdc.gov, that's the email address on the slide, and include your phone number. One of our experts will get back to you promptly. We've come a long way with our knowledge of the causes of infertility, opportunities for prevention, and development of technologies to successfully treat infertility, but we have a long way still to go to ensure that families across all population settings can safely have the number of children they desire. Thank you. And for the remainder of the time, we'll open the floor up for questions. If you could limit your questions to true questions and take advantage of our esteemed panel, we'd be delighted to accept them. In the back. The question was, we've noted an increase in infertility in women and asked whether there was such a relationship in men. There's a NCHS report. Well, I can't find it. It's impaired fecundity and infertility in the U.S., and what they found is that there's a slight increase with age, but not near to the extent that you see with women. Yes.
What is the reason why these treatments for fertility are not covered by insurance? Is it primarily cost, or are there philosophic differences?
Okay. I'm going to let Dr. Adashi or Ms. Galura, maybe you both want to comment on this one.
Thank you for the question, although I'm not sure I have the entire answer for you. I would say this. Whatever mandates currently exist, they have been almost invariably the result of grassroots efforts. That is to say, the patients, in many very ingenious ways, mobilized and influenced their state legislature and passed the mandate. By and large, professional associations, professionals in general may have been supportive, but not actively leading that campaign. Insurance companies invariably fought those efforts in each and every state, and once a statute was on the books, it has been revisited or challenged by the insurance companies the next year around. And so there's been an ongoing effort to actually protect what has already been accomplished. I'm not sure really why this has been such a divisive or complicated issue. May come back to some of the comments made earlier about how society, perhaps even a component of the medical establishment, views infertility as a non-disease, as some would argue, although we've heard, I think, good arguments to the contrary today. But there hasn't really been, I think, a concerted, unified effort that includes grassroots efforts, so the consumers, the providers, their professional associations, and hopefully, if we can get them within our ranks, health insurers as well. It's that combined effort that probably will be necessary if we're going to move this to a national scale, as distinct from essentially having 6 states that effectively cover IVF today.
Barb.
That was an excellent response, and I just want to make sure for those on the webcast, the question had to do with why doesn't insurance cover infertility treatments? And I would agree with everything Dr. Adashi said, and I think that it hasn't been viewed as a disease. It's been viewed as a lifestyle choice. I also think that due to the multiple births, insurers have been concerned about the cost, but there's a baffling, illogical reason when you look at that, because they're going to cover the pregnancy and they're going to cover those births. And so they're going to, in essence, cover the consequences of that lack of insurance. Mm-hmm. And so we are seeing movement in the insurance field to provide some smarter coverage options in a few policies in a few states. So that's very, very encouraging. And I do think the increased use of single embryo transfer is really showing the insurers that smart use of IVF can be very effective and lower or eliminate those downstream costs for those adverse health outcomes.
Susan?
From our online audiences, what are the implications of classifying infertility as a disease with regards to stigma?
Well, I think I would start this off by saying you've seen a huge sea change in how we view infertility. Used to be 20, 30, 50 years ago, it was a very stigmatizing disease. And I think that has lessened over time, in part because of the efforts of professional societies, but also the consumer-based organizations such as Resolve, the American Fertility Association, where people are willing to have this conversation now. The fact that we have a grand rounds today speaks to the fact that is further becoming destigmatized. And so certainly the recognition by professional societies of infertility as a disease certainly underscores its role as a public health issue. Okay, can you please, those in the audience in the room, if you could please go to a microphone. There's one on the left, one on the right. Thank you.
Not many environmental factors were mentioned today, and I'm wondering if we have any studies conducted on the effects of endocrine disrupting compounds in the environment and in the food supply on infertility.
Sure. Thank you for raising that question. There are some environmental exposures, also occupational exposures, phthalates, pesticides, solvents. The best person to answer these questions are actually in the room. So I'm going to punt this one to Dr. Richard Wang, who's actually sitting right in front of you.
Thank you for the opportunity. There are studies, and the studies can be enhanced, and that's what we're looking at to get better answers. So,
Steve, did you have anything to add? Okay. Susan.
Again, from our online audiences, in recent scientific review of the relationship between stress and disease, have the effects of stress been studied in regard to increased infertility?
I know there have been studies of stress and the relationship to infertility that have shown a positive relation. Dr. Adashi, do you know anything about this literature?
No, I will concede ignorance as to the literature, but I think anecdotally it's been commonly seen and accepted. Couples who have struggled with infertility and were successful one time, one way or the other, and were relying on infertility therapy, proceed to have spontaneous children thereafter. For no obvious reason other than perhaps, among other things, a reduction in the overall impact of stress. There are bound to be, or I hope there are, some meaningful studies out there on the issue, but I'm personally not aware of them.
I think there does need to be more research in that area, and I think this goes for a lot of the potential causes of infertility, and that includes the environmental and workplace ones that we mentioned earlier. There's a lot of suspect causes, but we really don't know near as much as we would like to.
Hello. Hi, I'd like to know how likely are patients to use the controlled ovarian stimulation if they find they're pregnant with more than one child, and how complicated is that procedure?
I may have missed the first part of your question.
How likely are patients to use the controlled ovarian stimulation if they find they're pregnant with triplets or quadruplets?
Well, let's put it this way. At present, by and large, the sequence or the progression is such that a trial of controlled ovarian stimulation usually precedes the deployment of IVF. The number of cycles vary. This is a non-invasive procedure. It's a more affordable procedure. If time is on one side, arguments could be made that that might be a logical way to proceed. The more advanced the age of the individuals in question, obviously there is a greater urge to move beyond the controlled ovarian stimulation, something I referred to briefly as the direct path to IVF. And I think more and more we are seeing of that, in part because of the ever-diverging efficacies of these two techniques. The best one can hope for with a controlled ovarian stimulation cycle is, by and large, 10% pregnancy rate per cycle, whereas with IVF, the rates are far in excess of that. Back in 1987, that was a different conversation. The two success rates were by and large comparable, or at least much closer together. But we are now a quarter of a century past that, and the overall impression is that controlled ovarian stimulation as a central tenet of our therapy is losing its rationale and probably will gradually diminish in its overall employment.
Any other questions?
Hi. Thank you all. That was wonderful, wonderful talk. My question is about primary prevention for infertility. And I think we recognize there are certain groups that that's an effective strategy for. I guess the group that comes to mind most is those who are undergoing chemotherapy or surgery that's going to affect their reproductive organs. Does the National Action Plan specifically address fertility preservation for these at-risk groups? And also, does it address the big ethical question of primary prevention for age-related fertility decline?
The action plan does address the issue of fertility preservation. It was actually in a lot of the comments that we received and was posted for public comment and from the pressure societies urged us to include it and applauded its inclusion. So it definitely is included. As a reminder, we want to make sure that we raise the issue in today's talk as well. Regarding your second question, remind me one more time.
So the controversial issue of fertility preservation for women for age-related fertility decline. I'm thinking about over 10 years of my practice, more and more 35 to 38-year-old women come to me and say, what can I do? I'm not married, I'm not ready to have children, my career is taken off, and I want to delay this, and I don't have a great answer for them.
Well, so aside from a diagnosis of cancer.
Correct.
Okay. The guidance does not directly deal with that. Certainly, you can speak with a clinician about that.
Thanks.
Barb.
I just want to add that the IOM had a meeting last year on cancer in young adults and adolescents, and over and over and over, you hear that the survival rate for adolescents and young adults with cancer has improved so greatly that now the issue is quality of life. And one of the, if not the number one issue that men and women have is, will I be able to be a parent? And I want to note that fertility preservation treatments are not covered by health insurance. So we have a lot of work to do, because I certainly hope that we can tell those young adults and adolescents that yes, they can be parents, because the medical technology does exist, and their insurance is going to cover it. But today that's not the case.
Let me just briefly add a comment, again, in response to the last question. In the non-cancer setting, simply aging related, I think the consensus or the trend is clearly moving towards fertility preservation under those circumstances as well, in the absence of disease, whether it's through the freezing of oocytes electively at some point, or some other means which perhaps are beyond the scope of this conversation. But I think the sense that I think many of us are beginning to realize is a shift in that direction as well. And so fertility preservation is not just for cancer anymore. I would say it is for age-related issues as well, although that's a tad behind, I think, the cancer movement.
Dimitri.
I just want to add that cryopreservation of oocytes is now non-experimental according to the American Society for Reproductive Medicine and Society for Assisted Reproductive Technology. And I think we'll know more about these procedures and the outcomes of these procedures when we collect more data and see the outcomes of these procedures.
I want to come back to your question one more time, because what the plan does say is that it's inclusive of all types of families. So there's not a prescribed, it was written in such a way to be inclusive.
Yes, thank you for an excellent presentation to all of our speakers. My question is whether the perception of a higher chance of multiparity is driving overuse of these therapies among women without infertility?
Are you suggesting that women who don't have infertility are electively doing IVF? Is that what your question is?
Yes, and I actually have very little background on this, so I was just curious.
As somebody who's gone through IVF, I don't know anybody who would electively go through IVF. So
Perhaps.
from the infertility community, that thought is very odd and strange. So
Perhaps not,
but maybe Dr. Adashi can tell us if elective...
Maybe not IVF so much as the use of clomiphene to increase the chance of multiparity?
No, I think in the absence of a circumstance that would be difficult to come up with right this minute, I don't think that's a common phenomenon. I'd say it's all but unheard of.
That it. Okay.
And Hi, I'm sorry to cut it off. It's such an interesting debate. But thank you very much for joining us, and we will see you next month.